Greetings, I'm Dr. Kim Kyung-won of Online Surgery. Today I'm going to talk about using one guide and placing 6 implants in the maxilla. This is panoramic x-ray at patient's initial visit. The patient is 58-year-old male patient. In the case of upper right posterior side, you can see that there's bridge on the 2 implants. There's a lot of mobility on the teeth. Number 27, it's quite solid and sound. In the case of this patient, he has hypertension and diabetes. Diabetes was somewhat managed. However, the patient was taking antithrombotic agent due to hypertension. Because the patient also has diabetes, rather than doing immediate loading, I decided it would be better to wait after extraction, and I provided temporary denture to the patient to adjust the occlusion and then place the implant. The decision was made to extract all teeth except for implant and number 27. As shown, extraction was done. The teeth, there were a lot of mobility and they were not in good condition and they were removed. This is x-ray after extraction. 3 months after extraction, as you can see that extraction sockets are somewhat healed. I took a CT in number 14. The extraction socket is not fully healed, however, gingiva, it looks clean, and in number 13, 23, 24, and 26. You can see that the alveolar bone is fairly in good condition. One guide is going to be used to place 6 implants. I'm going to talk with the one guided team so that the design plan can reflect anchor pin if necessary. Although it looks okay in the posterior side, number 14, 13, number 21, I'm going to place 1 here, number 23 and 24 and 26. I'm going to place 6 implants. If you look at the surgical report, number 14, it's going to be okay. Buccal area, it looks quite thin, but it's not a major issue. In the case of number 13, the buccal bone is quite thin. If necessary, GBR may be needed. As for number 21, although it looks like knife's edge, I believe it will not be a problem in placing the implant. Number 23, this is most problematic. In the plan on the CT, there seems to be a bit of residual bone and position was decided like this. I considered relations with adjacent teeth and the position was determined. I decided that it may require additional bone graft. Number 24, 26, 5.0 by 10 millimeter implants were to be placed. A total of 6 implants are to be placed for this patient. KS is going to be used. A 4.0 drilling is going to be done. The bone itself is assumed to be normal bone. Initial drilling is going to be done. 3.5 and 4.0 drilling is going to be done. In the posterior area, 4.5 is going to be used. The most distal tooth, number 26, I'm going to place a 5.0 implant. That was the plan. This is post-op image. Immediate post-op image. After implant placement, CT was taken. In number 14, you can see that implant has been placed in the desired position. In number 13, the labial and buccal side, the bone was quite thin. And you'll be able to see it in the surgical clip, but step incision was done and it was undermined for bone graft. The position was in the desired position. In number 13, additional bone graft was done as shown. CT was taken again. In number 21, implant has been placed to the planned position. In the case of number 23, buccal bone was more limited than expected and it was slightly deviated. However, this is not a major issue. Compared with other areas, the ridge itself was more narrow and the tapered implant was slightly labially inclined, and I removed the template and placed the implant more palatally and more deeply. I thought that the prognosis will not be very good. I placed it deep towards the palatal, and on the labial side, I did bone graft. As shown, I did bone graft both in and out of the extraction socket. You can see that there's very little alveolar bone left. It almost looks radiolucent, and I used bovine bone to do bone graft, the bone in both in and out of the extraction socket. In the case of number 23, I repositioned the implant on purpose. In number 24, the implant has been placed to the desired position. In number 26, you can see that implant has been placed nicely. In the case of number 23, I changed the implant and did bone graft, and this is post-op panoramic image. The position looks good here, and this was how surgery was completed. In the case of this case, I utilized one guide for planning. The position of number 23. Our original plan was to do GBR because bone condition was bad. However, the implant was slightly more labially inclined than planned. Additional bone graft was done. In the case of number 13, additional step incision was done to do bone graft. I'm going to show you in the surgical clip. First, one guide template is adapted to check if it fits well. The one guide, you can see that it is very stable and it fits well on posterior area of both sides. I believe we do not need anchor pin. Tissue punch is done to remove gingiva. I started off with number 14, 13, 21, 23, and 24. They're all regular hole, and tissue punch was done. On the other side, in the case of number 26, it was wide hole. Wide tissue punch was used. Template was removed to check whether the tissue has been removed thoroughly. I removed the gingiva and I'll proceed with surgery. I do initial drilling in number 14. 3.25 by 10 millimeter one-guided drill is used. After that, as final, 4.5 by 10 millimeter one-guide drill is used. KS3BA surface, 4.5 by 10 millimeter implant is used. This is a hydrophilic implant, therefore you need to do irrigation ahead. I'm using engine about 80%. After that, I'm using implant driver and torque wrench to get to final position. Primary stability is good, approximately 46 Newton centimeters. In the case of number 13, initial drill is done ahead. Because it is canine area, I used path drill. Path drill is used so that it is not slipping. Final drill is 4.0 by 11.5 millimeter one guide drill. This is the BA surface implant, therefore you need to irrigate it sufficiently using saline. I'm going to place it with engine about 80%, and after that I'm going to use implant driver and torque wrench to place the implant. The slot is here. The primary stability is very good. Number 21, initial drilling is done. Its anterior area, path drilling is done in order to prevent any slipping. In the case of interior area, in order to prevent the slipping, path drill should be used. Next, I'm using 3.5 by 10 mm one guide drill. Final drill is 4.0 by 10 mm one guide drill. And then implant is placed. Because it is interior area, I check the path using depth gauge, and I use KS3BA surface. I irrigated sufficiently. 4.0 by 10 mm is used to place the implant. In the case of number 23, initial drilling is done. 3.5 by 11.5 one guided drill is used. 4.0 by 11.5 one guide drill. BA surface, which is hydrophilic. Such implant is used for implant placement. Number 24, initial drilling is done. Next, 3.5 by 10 mm one guide drill is used for drilling. 4.5 by 10 mm one guide drill is used. This is the same. Implant is irrigated sufficiently. 4.5 by 10 mm implant is placed. In my case, I use one guide. When you use one guide, you can drill all at the same time and place the implant. However, I prefer to do it one at a time to reduce deviation. In the case of 26, this is wide. Initial drilling is done. 3.5 by 10 mm. Drilling is done. This is upper posterior area. Bone condition, I assumed it will not be very good. I did not drill full length, 4.0 by 10 mm. However, I did not do full drilling. And then I'm placing the implant. It is sufficiently irrigated. I'm positioning the implant. 5.0 by 10 mm implant is placed. Implant driver and torque wrench is used. As you can see, although it is upper posterior, as mentioned, final drilling was not done fully and primary stability is good. Primary stability, I wanted to check it, and I connected smart peg. I used Oslo beacon to check primary stability. As you can see, in the case of 14, it is 76, 13, 75, 21, 78, 23, 78, 24, 80, 26, 80. Primary stability were quite favorable. Healing abutment were connected. As shown, implants are placed. Primary stability was favorable. The healing abutments that I've chosen were quite short because the patient is going to use temporary denture. I didn't want it to become too long. I took CT As mentioned before surgery, number 13, labial bone is quite thin. In the case of number 23, it is quite inclined. In the case of 23, it has been placed slightly different from the original plan. The original plan was more palatal. Number 23, I removed it and I did side cutting and changed the position of the hole and placed the implant freehand, did bone graft. I'm going to show you how it was done. As you can see, number 23, in order to remove it, healing abutment has been removed. The implant driver is used, hand wrench is used to remove the implant. After that, depth gauge is used to check the insertion path. Side cutting drill is used to make it more palatal. I'm changing the angle. Depth gauge is used, and I checked whether the drill hole is more towards the palatal side. I used 2.2 twisted drill so that it is more palatal. Depth gauge is used to check that the path of the new hole is indeed different from the original hole. 3.5 by 11.5 1-2 taper drill is going to be used for drilling. Depth gauge is used once again. You can make incision here, however, I started off as flapless, so I just checked the path like this. Next, the final drill is 4.0 by 11.5 1-2 taper drill. After that, the KS 4.0 by 11.5 implant is going to be placed more palatal. In this case, stability may not be very good, however, it is quite favorable. On the labial side, you can see that there is gap. When you do smart peg connection, stability was comparatively favorable. It was approximately 70. In order to do bone graft on the labial side, healing abutment is connected. The space was slightly tight to do bone graft as is. Minor incision was made, flat was undermined, and bone graft was done. You can see that there is a thin bone on the labial side. I'm going to do bone graft in and outside of the extraction socket. I'm going to use bovine bone EOS sufficiently, like this. The flap is not fully reflected. In number 13, step incision is made. Undermine is done. The implant is not fully exposed here. EOS bovine bone is used for bone graft and GBR to augment the labial side. And surgery is now going to be completed. I'm not going to use any special collagen membrane. I just sutured. You can use particle bone, or recently there are bone graft materials that are mixed with collagen. Number 23, I'm doing suture to complete the surgery. You can see that the position of number 23 has changed more palatally. On CT, when I use one guide, in this case, because it was posterior area of both sides, one guide itself did not rock. However, buccal bone was thin and palatal bone was hard, and it was slightly labially inclined. It's not excessive. Maybe we had the wrong plan initially. I decided to place the implant once again in number 23 and decided to do bone graft on the labial side. I used one guide to place 6 implants. In the upper posterior area, in the case of anterior area, tapered body TS3 or KS3 implant can be used for implant placement because the palatal bone is hard and the implant itself is tapered. At times, it can be labially inclined. After implant placement, if you look at post-op CT or panoramic image, if the implant is not placed in the desired position, you can change the position and replace the implant as shown in the surgical clip. Thank you for watching.